Hi, I'm Adil Fattar and welcome to this series of videos. These videos are part of your consent process, which includes the consultation with me, the written information I gave you in the clinic, and the letters in the post. These videos are generic and an aide-de-memoire, so feel free to watch them as many times as you like, jot down any questions you have, and I'll go through them with you in the clinic at our next appointment. If you're not one of my patients, these videos do not constitute independent medical advice and shouldn't really be used outside of the context of a consultation with me. Either way, I hope you find these videos interesting and informative. So what would you expect from your mastopexy or breast reduction surgery? Both are daycase procedures, meaning you can go home the same day unless your procedure is performed later in the day. You should wake up following your surgery wearing a bra. I normally advise you to buy 2 bras of the cup size you plan to have. There should be non-underwired, well-supporting bras that hold the breasts in a good position without movement for your own comfort. In the first day or 2 you'll notice some bruising, and of course the breasts will be tender. I generally use local anaesthetic to try and minimise post-operative pain, but you will feel some discomfort. Immediately following surgery, your breasts will have a square, unnatural appearing shape, and the reason for this is that we know the breasts will drop over time. So early stages are geared towards overdoing the lift on the breasts so that they drop into a natural position that looks good a few weeks to a couple of months down the line, rather than starting in a good position and then the breasts sagging further over time. Occasionally a drain will be used. In most cases this is not necessary, but in some occasions I do feel it's prudent to place a drain, in which case you'll stay overnight and the drain will be removed in the morning. Typical things that happen following your surgery, or things that you should expect to happen. Of course, the first thing is the scar. You should expect to have an anchor-shaped scar. Smaller scars can be used, but it's the most common. This scar goes around the edge of the nipple, down the front of the breast, and underneath the breast in the fold. This scar is tightest at the T-junction, usually in the middle of the breast underneath. At this point the wound tends to open up a little bit. You may have stitches that will come through the skin, being extruded or spat out. This is much like a splinter being pushed to the surface of the skin. Once the stitch is pushed out or extruded, the wound heals usually fairly quickly. You may find yourself needing to wear a piece of gauze or dressing material in your bra for a few weeks following surgery. Towards the breastbone area, there is a risk of keloid scarring. This is a hard, lumpy scar that gets quite thick and obvious. Think of those patients who may have had heart surgery with a thick, lumpy scar down the front of the chest. It's not something I see commonly, but may require steroid injections or referral elsewhere for help. Out towards the armpit area, there may be a fold of fat or skin, sometimes called a dog ear. Normally we try and get rid of those as part of the procedure, but sometimes they may persist. If they're a problem, they can often be removed under local anaesthetic. The scars can be red and lumpy for anything up to 12 to 18 to 24 months, depending on your skin type, but many resolve more quickly than that. The scar around the nipple is the giveaway. The nipple doesn't transition in colour to the skin, but is now a defined border between the nipple and the skin, separated by a scar. The nipples may not be perfectly round, especially in the very early stages. Often the nipples can look quite unusual after the surgery, but will settle quite quickly within a few weeks. The scar down the front of the breast is the one that most people are afraid of, but actually is one of the ones that heals the best, often fading or blurring over time. It's quite hard to explain to patients that this will occur, but I've many photographs to show. Sometimes the scars may be sensitive. This is not something that I've noticed particularly in my practice, but it's something that I have heard of. Some patients may have a seroma, a small fluid-filled cavity in the breast. Usually this is absorbed on its own, but may require a needle drainage in the office. This is fairly painless, as usually the tissues remain numb and it occurs in the early stages. I've not had to deal with this myself. I've not generally seen it in my practice, but it is something that is a recognised complication. Asymmetry, differences between the two sides, are guaranteed. There's no way I can make both breasts look exactly the same. One patient said to me they should be sisters, not twins, and so such differences within normal limits I would accept. Obvious differences between the two sides would merit counselling and potentially further surgery. Fat necrosis can occur, and this is when the blood supply to the tissue of the breast is reduced, making the liquid fat form hard lumps. This is obviously concerning because your first thought would be that a breast cancer lump had appeared, but it typically occurs around where the surgery has happened. The nipple may change in sensitivity, becoming numb or more sensitive, or going through phases of both. Usually this resolves, but it may be permanent. Particularly in mastopexy, bottoming out can be an issue. When we talk about bottoming out, it means the tissues are sagging and the breast is giving way again. Often you'll have had an uplift because the tissues are poor quality and unable to maintain the breast in its higher position. In spite of performing the uplift, you may find that the breast over time inevitably still goes down and descends into its position. It's usually never as bad as it was before, but there's always some degree of bottoming out. We regard bottoming out as the enemy of mastopexy and do everything we can to try and avoid it. Rare complications and serious complications of breast reduction include clots on the legs, DVTs. These clots can break off and embolize to the lungs, which may manifest a couple of weeks later by breathing difficulties requiring admission to hospital. Other risks include bleeding after surgery or bleeding during surgery requiring transfusion. This is very unusual. Bleeding after surgery would mean you'd have to return to theatre as an emergency. We would open up the incisions, stop the bleeding, put everything back together, and then return you to the ward. Would this affect the final outcome? Probably not, but it will make your recovery slower, longer, with more bruising and swelling. Infection risk is generally low in this procedure. I would estimate it around about between 2 and 5%. Typically infections are on the surface and would resolve with antibiotic tablets or liquid. Very rarely though, you could get an abscess inside the breast. This would typically manifest as feeling slightly unwell, the wound opening up a week or two down the line and pus coming out. If this occurred, you may need readmission, antibiotics through a drip, and even a return to theatre to wash out the area. It would then be left to heal on its own. One of the most feared complications in breast reduction and mastopexy surgery is nipple loss. During the procedure, the nipple is moved on a stalk of tissue with its own blood supply. This could be damaged and result in necrosis of the nipple. The nipple turns blue, blisters and turns black, and you will lose part of the nipple. This may take dressings for quite some time. Thankfully it is rare, but you may require further surgery such as nipple reconstruction. If problems with the nipple are noted during the procedure, then a free nipple graft is performed in order to maximize the opportunity for a successful outcome. Cosmetic complications of breast surgery, these include overcorrection, in other words, I've over-reduced the breast reduction and made your breast too small, or undercorrection, they're not as small as you want, or in mastopexy surgery, they've been lifted too high and stay too high, or they've not been lifted as much as you expected. You may simply not like the appearance of the breasts after the surgery. In the early stages this is to be expected, as they will not look normal to begin with, but will over weeks and the first couple of months or so adopt a more natural shape. But long-term results that you do not like may be an issue for you. We will spend lots of time together trying to ensure that what you have in your mind's eye and what I can achieve for you are the same thing. In this day and age, when we're taking lots of photographs of one another, your breasts will always want to look their best in clothes, however you wish to portray yourself. However, surgery cannot make the breast look perfect in all angles, all the time, in all lightings, and there will be angles and situations where you don't like the appearance. This is normal. Surgery cannot make things perfect all the time. Breast reduction and mastopexy surgery aims to give you good results, especially when you're wearing clothes, but outside of clothes you will have telltale signs of surgery and small things that may give you dissatisfaction. Nonetheless, the vast majority of patients get great benefit from both these operations.